can ask, excellent, thank you. We do have one of our speakers with us, Rocío López from Internews, which is excellent, which is enough to get started, and folks are gathering in the room. Hi, everyone. I am Autumn Lerner, Senior Director here from Pandemic Action Network. A pleasure to welcome you to our Behavior Change Communications Working Group. This is a new time. This has been a monthly group that we have gathered each month, actually since the network started way back in April of 2020, which seems so long ago. But at that time, behavior change communications was one of the few tools that we had to really bolster the response in the early stages of the pandemic before we had other tools and treatments, vaccines in place. And this group has really been a hive mind and a place to share insights and intelligence on best practices for behavior change communications, but also community engagement and community-based approaches. So thrilled to have you all gathered today. Just a couple housekeeping updates, and then we'll go ahead and get started. But Darcy Sawatsky, who's been our typical chair for this meeting, is out today. She's actually off in Australia for a family vacation, but her role is actually also shifting. She has been a lead executive at Evoke Kind, a behavior change communications agency, until just this week. And she's leading that role, but she will still be part of this group moving forward. And then as we look at this group, just a preview, this will be our last meeting for the summer. We're actually going to go on holiday for August. And we're taking that opportunity to really evaluate kind of the most strategic role for this group in integration with our other policy and advocacy work at Pandemic Action Network. So we'll share that again at the end of the call so everyone knows what to expect. But just wanted to anchor us before we get started. So with that, I am looking here to see if we have our second speaker has joined us. I don't see that she has yet. But Rocío López from Internews is here. I'm really pleased to introduce her. She's actually going to be sharing some really interesting work that she and team have been doing on understanding trust and communication and collaboration between the media and humanitarian organizations, which I think is really relevant to all of us. So Rocío, I'll turn it over to you. So excited to have you joining us today. Thank you.
Thanks so much. I'll be sharing my screen just very quickly. Okay, I don't have the permit to share it. Can you grant me?
We will take care of that for you. Just a moment here. I think I can share my screen here. Oh, no. Emlyn or Hannah, thank you. There we go.
Okay, great. Thanks so much. So hi, everyone. I'm Rocío López. I'm the Community Engagement and Accountability Advisor for the Rooted in Trust project, a project from Internews. And as Autumn was just sharing, I'm here today to talk to you about the latest findings in a research that we recently published, which aims at understanding the gaps and the challenges that media and humanitarian actors have been facing in the communication and engagement with one another during public health emergencies, and how that ultimately has impacted their work. So next slide. Just very quickly on the research, we conducted it across 9 countries, and we surveyed more than 50 staff from humanitarian and health organizations and more than 50 journalists and media. Next slide. So I will go over the main findings of the gaps and challenges now, and then I will focus on the main recommendations on what we can do right now before the emergency, or how we can also contribute to create better preparedness structures also for this sector, for media. So next slide. In terms of findings, one of the main issues that was voiced and shared by both actors, actually by humanitarian and health organizations and media, was the scarce specialized capacity on the side of media and journalists to cover technically complex health issues. And this is not new to us. We saw it during the COVID-19 pandemic. But many of us, many of them actually stressed and emphasized how this was still necessary to pay attention to, because there was a lot of information, not only on health, but also on humanitarian dynamics and the humanitarian concepts and jargon that it's used sometimes by NGOs and agencies, that it's often missed by media and journalists, and that becomes also a significant source of misinformation as they try to identify what is being said and trying to interpret and analyze a bit on their own the health information. Next slide. It was also mentioned by both groups how there's a lack of common collaboration and collective approach, especially at the very local level. Media is never or rarely invited to coordination platforms, so it's missed this point of understanding media as another partner in the response, and certainly a relevant one to collectively think about solutions, because they are not present in these spaces. There is significant gaps in information sharing, identification of common needs, and also limited understanding of priorities on the side of media, especially also on the side of decisions taken during the emergency. So this leaves space for unanswered questions and increasing suspicions and mistrust, again, on those decisions taken on, or the secrecy of the steps that are being taken. Moreover, it's also a missed opportunity to identify opportunities for collaboration. Next slide. We also identified some tensions in terms of the different objectives and principles that both groups hold on to, and how that also contributes to create further mistrust between these two groups. On the side of humanitarian and health organizations, we identified how there was increasing frustration in aligning the different goals and timelines. So let's say humanitarian and health organizations work towards a goal maybe more in line with SBCC approaches, or risk communication, which is the use of information to protect communities, for them to take decisions on their health, while the role of media and journalists is a different one, which also it requires maybe sometimes asking difficult questions, and this is something that humanitarian and health organizations are not always very open to. There's also the frustration with the ongoing demand for breaking news on the side of media, or the perceived fatigue with ongoing or protracted crisis, and how the media shifts to other issues which are potentially more newsworthy, but ignore all those other issues on the health emergency that are still important for audiences and communities. And finally, humanitarian and health organizations mentioned their fears of being misquoted or having issues covered with sensationalist angle, and ultimately transforming into an approach like an approach to control the narrative with key messages and maintaining like media relations as with a public relations approach, or maybe just focusing on visibility purposes and ignoring all that value that media can add to the health emergency response if we were to have like more open relations and conversations with them on the actual needs and gaps. Next slide. On the side of media, they mention not always being allowed to record interviews with humanitarian actors, then having humanitarian organizations, seeing humanitarian organizations as not fostering proper relations with them due to lack of time, or because they were doubting journalists' intentions or even professionalism, and how they were also uncomfortable with their mandate to report independently. Ultimately, they also saw how these organizations a lot of times restricted their access to those to the people directly affected by the health crisis. And this is something that actually organizations also mention because they also saw some potential risks with the exposure of vulnerable communities to journalists, and how that was clashing with their mission to protect these communities. Some of the risks that they were seeing was like leakage in sensitive information, having media and journalists doing interviews with poor techniques and bringing these people like to re-traumatizing them, and or having also them cover like issues with a sensationalist angle and perpetuating stereotypes on communities that are already marginalized or isolated. Next slide. Next slide. Yeah. In terms of local and minority languages and inclusion of communities, we also identified still an important language gap, and especially at the local level when we're discussing minority languages that a lot of local media speak, and the gap that still exists for them to access information that is normally shared maybe in the official majority language, or when we're talking about like humanitarian and health actors like international agencies, very often also in English or in French. Then we also saw a limited participation of communities in communications or leading media relations within humanitarian staff, and we also saw how in these organizations few staff are normally given permission to engage with media, and in some cases it's only expat leadership. So this makes it very difficult to maintain continuity in the relation with media and to maintain contextually informed engagements. Next slide. In terms of community information needs also like being met, and at the very local level, we identify how obviously like national media outlets and local media face different challenges, which are like explained in the report, and we cannot go over them, but especially in rural areas that becomes like a challenge to provide information on the immediate local events, and a lot of times like humanitarian staff and teams leading with media relations tend to be less present in these rural areas or have fewer resources available. So that transforms into, again, these local events or local information, which is useful and relevant for people living there. This information goes unreported. And finally, we also identify like a lack of co-creation among communities, media, and humanitarian and health actors. So social listening data, when it is collected by humanitarian and health organizations or community data, rumor data, is very often collected for internal information and to inform programming, but it's very rare that it's actually shared with media, and it's very rare that it's actually there shared for them to to respond to those gaps and information needs identified or misinformation identified from their own shows or from their own products. A lot of times that is transformed maybe into key messages or things like that, or press releases, but the data per se is not provided to media who could actually make a very good use of it. Next slide. And finally, in terms of risk, access, and stigma, humanitarian and health organizations identified how media only covers vulnerable communities when there is an extraordinary event. And a lot of times the infrastructure, physical or security challenges that impede the access to community makes it for them less likely to be covered and therefore underrepresented in media. And on the side of media, they also voiced their concern as humanitarian and health organizations were expecting them a lot of times to cover certain issues, but were not considering the safety of their journalists and the dangers that they were exposed to when having to travel to conflict zones. So this was obviously impacting the availability of certain media. And finally, they also saw how in recent public health crisis, journalists have been threatened and attacked for their coverage. So a lot of times they were also like weighting that in to assess whether they were like covering certain issues or not. Next slide. So this was up to here on the main findings, and now I'm gonna jump onto the recommendation section on what should actors do now to be better prepared and collaborate with each other in a potential public health emergency. Next slide. Okay. There was like a anyways, so before the emergency, so, I mean, this is mainly for humanitarian and health actors, like giving the audience in this group. So before an emergency, we should be like promoting trusting relations and trying to create the spaces and for coordination of the response where media is also involved. We should be establishing networks now with local media and information providers. Assessing also their needs to support the next health emergency. So asking now, what do they need to be ready for the next health emergency? And this obviously is in terms of capacity building, but also in terms of information exchange spaces, or in terms of equipment, in terms of access to different expertise. We should certainly like engage in those conversations at the very local level to understand and assess how and where we can support. And we should also discuss the role that media can play now in prevention. And with that, it means also thinking how to incorporate them into like preparedness plans, but also like funding and finding resources to support them also throughout the whole cycle, and not only at the peak of the emergency, as they actually need to have the resources to prepare in advance, and not only like connect their like content and their work to the very specific emergency moment, but actually see their role also in the health promotion and disease prevention or pandemic prevention, emergency prevention phase. In terms of spaces and for coordination of the response, as we were mentioning, we should be including them in more preparedness conversation and contingencies plan, and also consider the establishment of media task forces. So not only for the emergency, but also, as I said before, like before and post emergency, allowing like these spaces to be like a discussion forum, not only on the health science, which is obviously important, and they need the health technical briefs and the updates on the public health measures, but also to discuss like potential solutions, and again like consider them as another partner within the health emergency preparedness and response landscape, as they can also come with local solutions, and they can also guide us through the priorities of the community. Next slide. Yeah. We should also be considering how to reach better like social listening data, rumor data, community feedback data with media work. So considering that media, and especially like participatory radio shows or like interactive podcasts, like or webinars, like that a lot of like non-traditional media also conduct, and information providers, especially in humanitarian settings, consider them as like two-way communication channels, also to listen to community needs, and establish now the systems to record those questions, to record the concerns of their listeners, of their audiences, and even consider them as like also potential channels to identify like alerts in terms of like health service gaps or any other kind of alerts that may contribute also to broader goals within the public health emergency response, and not necessarily only within the RCC sphere or like the communication kind of field. This obviously again requires like this kind of changing or like shift, like mind shift, because just to understand that media is just not like a loudspeaker to messages and to our communication, but it's actually part of the community and can actually be a very relevant entry point to the community's concerns. Then in terms of supporting media sustainability and capacity building, we should be considering providing more training to media practitioners ahead of the next health emergency. So again, this is obviously quite like specific or like bounded to the context, but just so they're better equipped to cover technically complex health crises, and they're also prepared for when the emergency hits, to cover that specific issue without the necessary background information. Actually some journalists voiced how a lot of times in the middle of the emergency they were requiring very basic background health information, and obviously humanitarian and health organizations do not have the time and capacity at the peak of the crisis to engage in explaining like maybe very basic issues. So this obviously transform into media and journalists looking for information online and in not so reputable sources, and a lot of times also transforming into more misinformation. Then we should also consider, as I mentioned before, and plan for more resources allocated to media as part of information ecosystem preparedness, and also overall like health emergency preparedness. And we should work towards timely and locally relevant responses. So, for example, revising now protocols for media queries and work to lighten up clearing processes or bureaucracy to grant interviews, so media can access experts in a more timely way when it's necessary. Then provide internal training to leadership and technical roles within health and humanitarian organizations on the value of engaging with media. So again, not only for visibility purposes or like public relations, but actually to understand that media relations can also be like a core intervention of public health or to meet like broader public health goals. And finally, they should also be mapping media's most spoken languages and include staff within those organizations who speak the language, who are part of the community, and who can actually bring all the complex expertise to medias and journalists and their peers in the most relevant way. Next slide. So I have some more recommendations for during the emergency, but I don't know if I think we're maybe over time, so it's up to you, Tom.
Let's give you 2 more minutes to wrap it up, and then we can go to a couple questions before we go to our second speaker from Nigeria Health Watch.
Okay, great. So I can just very quickly go through the points. It's again like around the same kind of pillars of work, like continue promoting trusting relations. So not only discussing science, but also the why and how of the decisions taken, be open, fostering those relations, being open to questions, and also being transparent about challenges, gaps, and needs, respecting the media's mandate to hold actors, health actors and authorities accountable of the measures taken. So not being afraid of opening those conversations, because otherwise, no. Anyways, like media is gonna go for the information. So it's better that they hear from you and you have like the conversation on and open up to all the complexities of the health emergency than just remain silent. Then in terms of the spaces and coordinations, obviously maintaining this continuous engagement through these platforms that we mentioned, and also maintaining potentially like continuous technical briefs, like ensuring that there's like media dialogues with health experts, or also spaces to share those social listening data that we mentioned before. Next slide. Yeah, no, I mean, it was there, like also providing timely social listening data and discussing how to work collectively to address those issues. And finally, we should be going local, like in all the recommendations and in everything that was shared, like trying to understand that it's local capacity and also local colleagues, the ones that are better placed to respond to media queries. So we should always be like potentially like the bridge to connect those queries at the local level with the expertise also there, just because obviously they speak the same language, but they also understand local priorities. They may also engage with one another from a similar like belief system or understanding social norms, and also they can also bound those conversations to the specific needs of that health emergency. So in the end, it's about also avoiding like one size fits all kind of messages, or like press releases that may be relevant to share again the science and the technical part, but not to ground it in the reality of communities and contextual needs. And now it's time for your questions, if you have anything. Thanks so much.
Thank you, Rocío, and your team. That was incredibly rich and really, really valuable as we think about these challenges. And I think for many of us, we can relate to the challenges that you shared, either on the media side or on the humanitarian and community-based organization side. I'll start out with one question. Please raise your hand if you have any questions, or feel free to put them in the chat. We don't have a lot of time, but a little bit of time for Q&A, and then we'll move over to our next speaker. But in terms of my questions, I mean, I have a number of them, but one I'll just touch on is sheer capacity. There is a lot in here about like, we need to do this, we need to build these relationships, we need to build these coordination spaces, we need to shift our language. You know, it really struck me what you said about like jargon as a barrier, working in global health and working on the communication side of global health. This is something I'm always trying to strip out of our comms in terms of just putting an acronym to everything. Acronyms are incredibly exclusive, and not everybody understands what we're talking about. But as we talk about all these things that we need to do, capacity is a major issue, especially when we're in a crisis, and humanitarian organizations are responding. They're in crisis mode. And so they're really focused on responding to the communities that are most vulnerable, that are most in need, in order to mitigate that crisis as much as possible. So as we think about the work that needs to be done now, how can we build capacity and build relationships with media while juggling priorities? And a lot of the humanitarian organizations are also, you know, hustling for funding, and there's just all sorts of challenges. And so it's like we have to weigh the juggle all the time. What sort of resources are available? Are there any that Internews can highlight for this group?
Yeah, sure. I I mean, actually, like what we mentioned in terms of training, there's like a couple that we developed during the COVID-19 pandemic. I can share them after in the link. In terms of the very basics, at the moment was like the very basics of COVID. Then it came after like the very basics of vaccine technology, different types of vaccines, and this is something that was offered to journalists. Maybe my colleague Ida can after like mention something about that or share something in the link, in the chat. But actually it was like about the ultimate purpose of all this was to support journalists, but actually also to bridge that that expertise that health organizations had, and while they were also obviously like extremely busy in the middle of the pandemic and trying to respond to all the different needs that were emerging, like trying to have like us as Internews, we were trying to be that bridge between those two worlds and trying to bring that all that technically complex health information you were talking about, jargon and everything, to the journalist in the easiest way. And obviously that was trainings, but also that was like through cafes, like it's called media cafes or press cafe, where we were like discussing like every week or every couple of weeks like different issues, and also as the emergency was evolving. So for example, in the ISAR region, in Eastern and Southern African region, as part of the Media Sub-Working Group there, we were leading media dialogues that were taking place every 2 weeks, and each week we were discussing whatever was necessary at that time, like either identified through the information needs of the social listening data that we were identifying, or maybe because there was like a new like outbreak, we covered COVID, but we covered also the Uganda Ebola outbreak. We also covered monkeypox. So just identifying the priorities in the region and then having all those journalists there like this for discussion. So we were trying to have like within this 1 hour, like all the expertise is like kind of condensed there with the experts from the region, but also with journalists from or like media experts that could actually bring necessary reporting tips or tips on how to cover also issues such as stigma and disease, etc., etc. And then we were having these immediate feedback from journalists and questions from journalists on what they would like to see in the next session, or whether there was something that was not covered, and just assessing continuously their needs to have this open relation. So I would say, I mean, those are just two examples. Training, media dialogues. We were also drafting some guidelines, as you were mentioning, like, or glossary. At the beginning, there was all these glossary terms. Those these terms that were very difficult to understand if you were not part of the conversation. So we developed also those tips, reporting tips, guidelines. But I can share some on the chat, and you can take a look at it.
That would be great. We would welcome those resources in the chat, and we'll include all of them in the notes. And if you're open to us sharing your presentation with this group as well, we're happy to include that. Excellent. I see a question from Issa Tussar in the chat. How do we make sense of existing evidence to inform today's policies on collaboration? Issa, I don't know if you want to add context to that question. I'm not sure I totally understand the question. Though one of the things I read in it, as I read it, is like, you know, when a crisis happens, or particularly a public health crisis, there's evolving information that we as humanitarian organizations are making sense of while trying to, you know, inform really clear communications. And it's evolving, and that was definitely a challenge in COVID. And we see it in other public health emergencies as well, where from day to day, what we know changes. And that sort of inconsistency in message can be a challenge. I'm not sure. or risk
Okay,
communications to be
risk.
effective on values, perceptions, practices. Okay, I'm going to leave this question here for you to answer in the chat so that we can move on to our next speaker. And if you have other questions for Rocío, please put them in the chat. With that, we do want to make sure that we have time for our next speaker, who's joining us from Nigeria, Health Watch. I'm happy to turn it over to Kemisola Agbaoye, who will be sharing on work on social listening for health misinformation management, and specifically insights from Nigeria. Kemisola.
Hi, awesome. Thank you so much. Can you hear me?
Oh, yes.
Okay. And please confirm that you can see my screen.
Yes, we can. Excellent.
Great, thank you.
And so I would say let's take about 10 to 12 minutes to cover the high points of your presentation so that we have some time for Q&A.
No worries. Thank you so much. Hi, everyone. Thank you to the Pandemic Action Network for the opportunity to talk about our work. So we are a not-for-profit health communications and advocacy organization based in Nigeria. And what we do basically is advocate for better health, better access to quality healthcare for Nigerians. And we do that in a number of ways. Primarily our editorial, but we also convene strategic events, and we are very heavy on social media. We're one of the foremost organizations in Nigeria to use social media as an advocacy tool. But what I want to talk about today is our health misinformation project. And before I start, I wanted to give a bit of a background. We all know what a scourge fake news can be, and how injurious it was to the COVID-19 pandemic response. And we know that due to digitalization and the rapid spread of misinformation, or of information generally, misinformation also spreads very rapidly through those platforms. So in Nigeria, in 2014 to 2015, when the West Africa Ebola outbreak happened, there was a rumor about the use of salt water to cure Ebola. And this was initiated by a traditional ruler. And this led to the death of 2 people. And that, I think, was one of the first real evidence of how misinformation can hamper public health response, and how it can lead to more mortalities than necessary. And we saw what happened during the COVID-19 pandemic. Nigerians did not even believe that the virus existed. When time came to roll out the vaccines, they believed the propaganda around the microchip. And this was all fueled by a lack of trust in the government. So this led to the Take Responsibility and Health Fact Check Nigeria campaigns. Now, the Take Responsibility campaign was designed with our support, the Nigeria Center for Disease Control, which is a public health institute. And it basically was launched to manage misinformation, but also promote adherence to the public health measures and non-pharmaceutical measures that were the mainstay of the COVID-19 pandemic response. So we did this in partnership with MEDAN, and we were one of the first organizations to use non-text formats to disseminate fact checks. So we designed videos, infographics, comics, disseminated them in local languages across traditional and social media. And this is what really birthed the Health Fact Check Nigeria project, which is our social listening projects. It has both online and offline components. For online components, we leverage an artificial intelligence-powered social listening tool. We actively listen to rumors, misinformation, disinformation online, and then we conduct research to debunk them. Then we develop content, again, sticking to what we know is really engaging: graphics, comics, animations, videos. We have a web series, or a pilot episode of a web series out on YouTube as well. And for offline, we deployed community listeners in Niger State. It's one of the large states in northern Nigeria, and we had community listeners trained who then went into their communities and administered questionnaires, conducted key informant interviews, focus group discussions, and from these we were able to identify misinformation that were then debunked. One of the things we also checked for the offline listening was the most commonly used methods of, or most common sources of information. And we found that the most common source of health information, most trusted source of health information is healthcare workers. So I'll go into some more detail of how we use that information going forward. But first, let's go into a bit more detail on the online social listening. So like I mentioned earlier, we leveraged artificial intelligence. So we generated keywords for focus areas. Our focus areas were maternal and child health, sexual and reproductive health and rights, routine immunization, and a few others. So and mental health as well. So we we also developed a matrix for identification of which ones were misinformation based on levels of engagement, potential cause harm, and believability. How ridiculous was the misinformation that was identified? And then we also developed the data collection templates. Now, in listening and identifying, we had a dedicated team who listened and who applied the matrix they had developed to mentions and then categorized them as they collated them in the collection template. So each of the collated mentions then went through 3 levels of reviews. We have in-house experts who then went through the mentions and determined if they really were misinformation that should be debunked. There is the ongoing conversation about how best to approach misinformation. Sometimes there's a fear that when you take in misinformation that's ridiculous and you debunk it, sometimes the misinformation, you engender or foster further spread of the misinformation. So we had to be careful about what lens we use to select which ones to debunk. Then we conducted research in-house. We looked at peer-reviewed articles. We looked at publications from trusted sources such as the WHO or Nigeria Center for Disease Control. And then we adapted the debunks into simple messaging that were disseminated in infographics, videos, comics, and audio formats. And like I said earlier, we created a web series. The web series was created to debunk one of the misinformation that was identified online, which was on sexual and reproductive health, stroke, cancer. So it was a misinformation about how when a person has frequent sex as much as 21 days per month, then their chances of coming down with prostate cancer is significantly reduced. This is something that's still being debated by the scientific community, and we use storytelling to debunk that or to provide more information on that, essentially. So we disseminate on social media. We ensure to prioritize the platforms where the misinformation was identified to start with. So Facebook, Twitter, YouTube, TikTok, but the social listening tool also gathers mentions from online fora, blogs, from mainstream digital outlets, for example. And while we found that most of the misinformation was actually identified on social media platforms, we made sure to prioritize those. And we then tracked the performance of the debunks that we put out. So I'll just quickly go very quickly through the results and the insights. Some of the insights that we have gotten from this. We had 250,000 mentions over 6 months, and only 0.17% of these were actually misinformation. There were others who were not misinformation, but maybe there was just a vacuum of information. Some 10% of those we actually just did explainers for. But actual debunks were needed for 0.17%. And when I say general health, 40% general health, I mean things around cancer, things around hygiene, just a general health, essentially. And then we had sexual and reproductive health, maternal and child health, 12% nutrition, and then 5% mental health. We had misinformation around how mental health is caused by spiritual issues. This is Africa, and yes, we do get misinformation like that. and then on routine immunization as well. Not a lot of mentions on routine immunization, and that's where some of the insights come in. We actually found that there wasn't a lot of mentions on misinformation, and this is probably partly due to the fact that this was towards the tail end of the COVID-19 pandemic. Nigeria hadn't been badly hit, as we all know. And at that time, there was still a lot of, because Nigeria wasn't badly hit, there was still a lot of disbelief and misinformation around the COVID-19 pandemic. And a lot of the mentions around, or all actually of the mentions around vaccines were actually tied to COVID-19, to COVID vaccines. And then, yes, like I mentioned earlier, some of them are just information vacuums, and we just provided explainers for them. And we found that most of the misinformation was actually on Twitter, which is not surprising given the nature of the platform. There were a few others on TikTok, Facebook. These percentages might not be accurate. And then we had a very small number of them on online fora. The reason I said these percentages might not be accurate was because there's, this is not the most up-to-date slides, apologies, yeah. But there's 21% that speaks to TikTok, Facebook, and YouTube as well. Okay, so now I'll go to the offline social listening. I had mentioned earlier that we had deployed community reporters into 8 local government areas in Niger State, and they had gone on to conduct focus group discussions, key informant interviews, and they had also deployed a survey, and that survey had shown that over 50%, I think 56% of respondents said that healthcare workers were their most trusted source of health information. Right? Just stay on the slide, just so I don't preempt the discussions. So one of the things we did was train healthcare workers and health educators and some community leaders as well. Like I mentioned earlier, the rumor about the use of salt water to cure Ebola was actually spread by a traditional ruler. So we have in Nigeria, we have an accountability, a transparency and accountability structure for primary health care, which is what development committees, which consists of traditional rulers, religious leaders, basically influential people at the community level. So we trained these people to leverage their community structures to disseminate the debunks that were identified in their communities. We also trained healthcare workers and health educators on identifying and managing misinformation. We actually also showed them some of the misinformation that had been identified in their communities, and a lot of them did not know that they were misinformation. So one of the qualitative feedback that we got from them was, 1, we've never had this sort of training before. 2, this actually caused us to confront our own biases and some of the misinformation that we didn't know were in our communities and how to handle them. So we then went back to do a post, to do an online survey to see if anything had changed. The other thing we did that I didn't quite mention is we developed jingles that were disseminated via radio. And we also provided the healthcare workers that we trained with IEC materials. So they then went into their communities, the healthcare workers trained other healthcare workers, the community leaders trained their members of their community, leveraging community meetings. The health educators just went into the communities and did sensitization meetings with the IEC materials. So the combined efforts of all of these is what led to the changes that we then saw when we went back to do an end line. So we saw that misinformation had reduced significantly by over 30% for some of the misinformation that had been identified. People became more informed from 37% to 69% on this one, which is on childcare and breastfeeding. And this was consistent for most of the misinformation that we had identified. Then, so I just also wanted to just highlight some of the key achievements. I had also wanted to talk about some of the limitations that we had and to maybe just end with next steps as to have some time. So like I mentioned, we trained 8 community listeners, and these are now this is a structure that I'll just lump it up together. Key achievements and what we think we'll do with it going forward. So this showed us that there was a viable method for routinely, note that this wasn't conducted during a public health emergency. It was towards the end of the COVID-19 pandemic. Everyone had relaxed. And we found that having structures like this, the pilot showed us having structures like this is definitely a consideration for routinely collecting misinformation in communities and debunking them. We found also that leveraging existing structures is key, and knowing that it wasn't exactly top of mind. It's not something that healthcare workers get trained on during their training. It's not something that the government is conscious of, has led us to start thinking critically about how do we take learnings from this pilot and get the governments, state governments for one, to adopt this. How do you ensure that, especially because the people we trained said they had never had that kind of training before, how do you build capacity in a way that is routine and a way that is sustained? And then we also learned that, for example, local media organizations are key. One of the things we hope to do going forward is to build the capacity of local media organizations. About 21% of respondents from the survey had said that they get their trusted health information from local media, which is mostly radio at the community level. So one of the things we're thinking about going forward is how do you build the capacity of local media organizations? How do you foster listening via radio? How do you get community members to call into radio stations, and how do you equip the radio stations to then, what do they do with that information, and how do they ensure that the right information is passed across? So I will pause here. Thank you, and I'll just wait for questions. I think that's it. I hope that was high level enough. Awesome.
That was great. Thank you so much, Kemisola, and thank you for this work. It's really incredible to show kind of what is possible. One of the questions that I have that I'll kick off with, and then we'll have time for maybe one more question. And feel free to drop any questions in the chat, and we're happy to share them with Kemisola, and hopefully we can share your slides as well. I think there's some really great insights there. But you talked about, like, you don't want to platform really egregious disinformation, like rumors, myths. You don't want to be a force of spreading that, right? So we've talked about in this group before about this balance of debunking, where it's like, you may have heard this, but this is the fact, versus just flooding the market with kind of the positive messaging or the factual messaging, the clear message that we want people to hear, but from trusted messengers, whether that be, you know, frontline healthcare workers, community members, faith leaders, etc. How did you balance that? Because it is a sensitivity. You don't want to be a force of spreading a rumor effectively.
Yes, absolutely. That was definitely something to think about. So this being able to ensure that there's a balance and that we don't end up pushing out this information in a bid to debunk them is why we had the matrix. It's why we had the matrix and why we had the different levels of review before we selected which ones to debunk. So the matrix helped us because, for one, we looked at how many people were engaging with it. If it wasn't popular already, then there's no reason why you want to go debunk it, because you just get more eyes on it. Also, we looked at believability. How believable is that misinformation? This is highly subjective, yes, but having experts in-house who could look at that misinformation did help. And this was an indicator that we added on much later, because yes, and each of these metrics had a weight to them. So this information could be believable, but if the level of engagement wasn't significant enough, then maybe we would deprioritize that and not debunk. And then the third thing was potential to cause harm. That one was really important. If there was a potential to cause harm, say, for example, it means that a woman would not take a child for immunization or for vaccines, then yes, we would debunk. If it meant that she would discard the colostrum, for example, yeah, then we would debunk. If it would cause harm to anyone, a woman, her child, as long as it had potential to cause harm, then we prioritize that and debunk. There was one we debunked on the use of Beecham antibiotics, Ampiclox, something. Yeah, it's an antibiotic anyway, for abortions. And this was something that was spreading rather quickly on TikTok and Twitter, I think. So we debunked that because it would lead to non-judicious use of antibiotics and would continue to contribute to AMR. So those are just specific examples. It's something to think about, and it's something to be careful about. Having experts look at it and having metrics still help, but also it's something we're still actively learning about as well.
Great. I wish we had more time for more questions. Thank you for sharing this with us. And we will follow up with you on sharing the slides, and then also share notes from this meeting with everybody on the call today. As I noted at the top of our meeting, we won't be meeting in August. We're taking a break for an August holiday. And then we're also reevaluating kind of the next steps with this group overall, given our policy and advocacy priorities and our regional working groups. We have one in Africa, one in the EU, Asia Pacific, and Middle East and North Africa, and then we have our global group as well. So just thinking about how we better connect the dots and integrate this work with our overall work ensuring more effective pandemic prevention, preparedness, and response. Also, this group was originally scheduled to have its meeting during UNGA High Level Week in September, which we know many will be focused on and or physically there in New York. So we won't be meeting at that time. So more to come, but wishing you all a great evening, wherever you are, afternoon or day. And thank you so much to Kemisola, thank you to Rocío and team. And we will see you soon. Bye.
Thanks, bye.